Hello everyone, this is Dr. Wala Adri, lecturer or maxillofacial surgery, Cairo University and MIU University. In this video, we're gonna talk about maxillary sinus in terms of general anatomy and its clinical relevance. We're gonna talk about diagnostic aids, sinus pathology, cysts, tumors related to the maxillary sinus, and maxillary sinusitis or antral communication, and finally, sinus floor augmentation. Maxillary sinus is the largest of four paranasal sinuses present in the body of maxilla and skull bone, namely maxillary sinus, ethmoid sinus, and frontal air sinus, and sphenoid air sinus within sphenoid bone, and all opens through small ostium to the nasal cavity, which are all lined with respiratory epithelium, namely pseudostratified ciliated epithelium. Maxillary sinus is also called antrum of Higmore. It begins as a mucosal invagination within the maxillary bone, starting from the lateral surface of the nasal bone and grow laterally throughout the development of maxillary bone, starting with less than 1 centimeter and continue development through each year to reach the final volume at the adulthood. During its growth, it contributes also to the growth of maxilla in anterior, posterior, and inferior direction till full development. However, the development of maxillary sinus doesn't stop at childhood, but after extraction of upper posterior teeth, it continues development by a process called pneumatization. In normal condition and full dentition of the upper posterior teeth, the positive air pressure within the sinus is opposed by the occlusal forces falling on the upper posterior teeth. So, after extraction of the posterior teeth, this positive air pressure inside the sinus is non-opposed, and the sinus membrane starts to grow within the alveolar process in a downward direction, forming what's called pneumatized sinus. So, pneumatization is a continuous physiological process that causes the sinuses to grow and increase in volume within the alveolar process of maxilla, which in the normal conditions the sinus floor is above the level of premolar molar teeth. However, in some cases, these roots may penetrate the sinus membrane and cause post-operative complication following their extraction if not preceded by preoperative radiography. We're going to talk about the anatomy of maxillary sinus in details. Maxillary sinus has three recesses. Recesses correspond to processes in a bone. Bone has a process or more, and a cavity has a recess or more, meaning depression inside a bone. So we can see that the maxillary sinus or cavity spread to the alveolar process and zygomatic process posteriorly and the infraorbital superiorly. The maxillary sinus drain into middle meatus, which located below the middle turbinate. The opening of maxillary sinus is located high in the lateral nasal wall, as we'll see now, meaning 2/3 the distance up from the inferior part. The maxillary sinus is lined by membrane, as we said before, pseudostratified columnar ciliated epithelium in histological point of view, and this secretes mucus which traps the bacteria, and the cilia that cover this respiratory membrane move this mucus with the entered bacteria toward the ostium due to its high location in the lateral nasal wall. The maxillary sinus is pyramidal in shape, with the base being the lateral nasal wall, and the apex extends laterally to the zygomatic process, and superiorly has the floor of the orbit below the alveolar process. This photo demonstrates the middle and the inferior concha or turbinate of the lateral nasal wall. The maxillary sinus open in the middle meatus. The middle meatus, which is the depression below the middle turbinate. Here is in the coronal CT cut, there is inferior meatus and middle meatus, where the opening of maxillary sinus open. Notice the high location of the ostium of maxillary sinus, where it prevents the drainage in case of increased mucosal secretion within the sinus. Here is the maxillary antrum or sinus base, which is the lateral nasal wall, showing the inferior turbinate and superior turbinate, which cut, inferior and superior turbinate, which is cut, to show the ostium or opening of maxillary sinus into the maxillary or nasal cavity. Here is the roof of maxillary sinus, which is represented by the infraorbital margin, which contain the infraorbital canal that contain infraorbital vessels, artery and vein, and infraorbital nerve. Here is the inferior orbital wall with related vessels and nerve. Another sagittal view showing the infraorbital margin, in which run the infraorbital canal. You get to know the normal landmark to differentiate from the any pathology in the maxillary sinus. Here is the infraorbital canal as well. Also, that help you to differentiate normal from abnormal, that you should correlate, as abnormalities tends to be unilateral, while bilateral represent an anatomical structure. Along the posterior wall of maxillary sinus run the posterior superior alveolar nerve, which enters the maxillary sinus to supply the sinus and upper posterior teeth before the maxillary nerve enter the infraorbital canal to give the infraorbital branch. So the posterior relation include posterior superior alveolar nerves and vessels. Moreover, a depression posterior to the maxilla called pterygomaxillary fissure between the pterygoid plate and maxilla is a posterior relation. Here's what we said: posterior to the maxilla is a pterygomaxillary fissure, in which run the posterior superior alveolar nerve after coming from the sphenopalatine ganglion, which is suspended in the maxillary nerve, and a large venous plexus, which is a pterygoid venous plexus posterior to the tuberosity and maxillary sinus. The maxillary sinus floor is formed by the alveolar process of maxilla. Its level usually with the level of the nasal floor. However, after extraction of the upper posterior teeth, as we said before, the sinus floor is pneumatized or extend to the alveolar process, decreasing its height or volume. The sinus floor is also maybe irregular, not uniform, due to projection of the roots of maxillary teeth into the sinus. The roots even may perforate the sinus floor. The blood supply of the maxillary sinus includes the vessels that pass in these regions to supply either the upper maxillary teeth or the infraorbital structures, like the posterior superior alveolar nerve and anterior superior alveolar nerve, greater and lesser palatine, and nasopalatine. The maxillary sinus drain into the internal jugular vein through maxillary and anterior facial vein. Moreover, the pterygoid venous plexus, which lie posterior to the maxilla, receives contributions from the maxillary vein. The main lymphatic drainage of maxillary sinus is through the submandibular lymph nodes and the nose. The innervation of maxillary sinus involves two main innervation: sensory innervation from the surrounding nervous structures, that's namely the superior alveolar nerve with the posterior, middle, and anterior divisions. This nerve also innervates the corresponding dentition, anterior and middle and posterior maxillary teeth. Also, maxillary sinus is innervated by the infraorbital nerve from the superior part, greater and lesser palatine from the alveolar process part, and the posterolateral nasal nerve from the nasal side. The another innervation is the parasympathetic one, which It's responsible for the secretomotor function of the mucous glands of the lining, which comes from the greater petrosal nerve, which is a branch of the facial nerve. Here's figure demonstrates the innervation of maxillary sinus. Here is the maxillary nerve, which gives the infraorbital nerve and posterior superior alveolar nerve to the superior and posterior part of maxillary sinus lining respectively. And here is the middle and anterior superior alveolar branches, and here is the magnified view of maxillary branches to the maxillary sinus from the maxillary division of trigeminal ganglia. Now, to sum up the relations to the maxillary sinus, we can summarize it as follows. From superiorly, the infraorbital component and that include nerves and vessels, and from below the alveolar process and maxillary dentition, hard palate and the oral cavity, posterior pterygomaxillary fissure and its contents involving maxillary division and pterygoid venous plexus, and posteriorly the nasopharynx through communication with the nasal cavity. Coming to the dental relations, the most teeth related to the maxillary sinus start with the upper second molar, followed by the upper first and last molar, then the second premolar, first premolar, and finally the upper canine, with the closest root being the mesiobuccal root of upper 7 and the farthest one the buccal root of the upper 4. Now, what is the significance of knowing the closest relation to the maxillary sinus? Presence of infection in the periapical region, there will be an easy extension from the teeth morally related to the maxillary sinus. Plus, during extraction, you should know the most teeth related to avoid oral-antral communication by doing a forceful extraction. Moreover, chronic sinusitis or acute sinusitis, there will be referred pain from the sinus to the posterior teeth, which are highly related to the maxillary sinus. Here is the applied anatomy of maxillary sinus, means that application of knowing the anatomy to the clinical practice. Now, the canine fosite is the area of bone superior to the canine, which is the thinnest part on the facial wall of maxillary sinus, from which we perform an operation called Caldo-Lac operation that will be discussed later in details. It's usually 2 mm thick, the thinnest bone area on the facial surface of maxilla. The roof of maxillary sinus is represented by the inferior orbital wall, which is clinically significant during orbital fractures, that the muscles of the orbit may be entrapped into the maxillary sinus, or in chronic maxillary sinus infections, there would be symptoms related to the orbit. Maxillary sinus floor level in children usually maximum at the level of the nasal floor, while in adults is below the nasal floor or more in case of pneumatized sinus. The maxillary bone is the thinner at the upper 7 and 8 area, so there will be easy spread of infection from the upper 7 or 8 to the sinus. And biphasic growth here means there is 2 phases of growth of maxillary sinus. The first during the first 3 years of life, and the second being at from 7 to 18 years of life. The second topic with us is maxillary sinusitis. Maxillary sinusitis can be defined as inflammation of sinus and its lining, that is called Schneiderian membrane, due to microbes from different sources, either extrinsic source like the oral cavity and periapical infection of the upper posterior teeth, or intrinsic factor or the nasal passages like viruses, common viruses, influenza, common cold, or coronavirus recently. So maxillary sinusitis can be classified as follows. Number 1, according to the etiological factor, into odontogenic maxillary sinusitis and non-odontogenic maxillary sinusitis. The odontogenic one, as we said, caused by bacterial infection coming from the oral cavity through the periapical region of upper teeth, or periapical cysts, abscess, any lesion extending from the T approximate to the sinus, like upper 7, 8, 6, or whatever. Any infection from the periapical region extending to the sinus can spread the microbes to the lining and to the bone in case of decreased patient immunity. Also, pushing teeth, root, or implants into the sinus also transfer the oral microbe to the sterile medium within the sinus. Also, oroantral communication, facial fractures, severe periodontal pocket extending from the upper posterior teeth all contribute or introduce the bacteria to the sinus membrane. And non-odontogenic means sinusitis due to non-dental origin, like viruses, as we said, common cold, influenza, or coronavirus, or even fungal infection. Also, maxillary sinusitis can be classified according to the virulence of bacteria, virus, fungus, immune system, and the local tissue condition into acute, subacute, and chronic maxillary sinusitis. The odontogenic maxillary sinusitis, as we said before, odontogenic means of dental origin. It's usually unilateral. We have a unilateral periapical infection here related to the upper 7, which spreads the infection to the sinus lining. Here is periapical infection related to the upper tooth. Here is the spread of infection of the periapical abscess, made inflammation and thickening to the sinus lining. Here is you see the level of sinusitis, or inflammation of membrane of the sinus due to periapical infection of upper tooth. Here is the difference between acute and chronic maxillary sinusitis. Usually the acute maxillary sinusitis caused by multiplication of bacteria that invading the mouth that exceeds the limit of the immune response of the patient, while the chronic maxillary sinusitis result from prolonged low-grade inflammation. Means that we have a low virulence of bacteria or low number of bacteria, but prolonged duration, spread to the maxillary antrum floor, and following acute phase or a treated acute condition that has been recurred and turned into chronic, in which the mucosal lining of the sinus undergo thickening with edema, without that formation of sinus polyps. However, the main difference between acute and chronic condition of sinusitis is what's called general constitutional symptoms, which involve redness, hotness, edema, pain. All these occur in the acute condition. Redness or hotness occur on the facial surface of maxilla. Feeling of edema also is reported by the patient. Here's in more detail the clinical picture of acute versus chronic maxillary sinusitis. In the acute condition, there is headache, while in chronic sinusitis, the headache comes and goes, meaning intermittent, not continuous headache. The facial pain or the sinus pain that reflected on the facial surface of maxilla is severe in the acute condition, and it's pressure-like and increased by bending the head downward and forward due to the fluid level accumulation inside the sinus. As you'll see in the radiography later, there is fluid level that cause pressure on the anterior surface of maxilla during bending the head forward. While in the chronic condition, the pain is dull, not severe like an acute condition, and may be continuous. The discharge occurs in both acute and chronic condition with fetid or bad odor, and usually for acute condition it's unilateral with anterior or posterior discharge, meaning discharge from the nose, or posterior nasal drip from the nasopharynx. In both condition, acute and chronic, the discharge it's periodic and it comes and goes, also not continuous in the chronic condition. There is obstruction of acute condition and chronic as well, with unpleasant smell. The general constitutional symptoms in terms of fever, headache, malaise, we said it's only specific to the acute condition, any acute condition, not just maxillary sinusitis, any acute infection, has fever, headache, malaise, redness, hotness over the infected area, with usually a swelling associated. Erythema, one of the general symptoms, and the chronic condition doesn't have these general symptoms. It's specific to the acute condition. Also, the swelling confined to the acute condition of the cheek and anterior maxilla. There's a sensation of fullness due to the swelling of the acute condition, rarely in the chronic condition. In acute sinusitis, the dental symptoms include pain or tenderness of the upper teeth related to the maxillary sinus in the region of infection, while for chronic condition, the pain only ensuing due to confining the infection to the periapical region, with or without increased tooth mobility. On radiography, always the acute condition is negative, while in chronic condition, there are many variations, including either opacity, air or fluid level within the sinus, wall displacement from chronic infection, or mucosal thickening or sinus lining polyps. Transillumination, as we'll discuss later, by application of light over the facial surface of the sinus, the light will pass due to clearance of the sinus in the acute condition, while in chronic condition with accumulation of secretion, there will be opacity or obstruction of the light passage through the sinus. So we can divide the acute maxillary sinusitis as a disease lasting less than 1 month, while the subacute condition a disease lasting from 1 to 3 months, and the chronic that extend more than 3 months. Usually the acute and subacute condition respond well to the medical treatment, with full resolution of the condition or turning into a chronic condition in case of improper treatment. In chronic condition, we can start with the medical, but usually the condition requires endoscopic sinus surgery to either widen the maxillary ostium. We said before, the maxillary sinus opening to the nasal cavity located in high location on the lateral nasal wall, so dependent drainage or drainage by gravity is prevented, so we perform endoscopic sinus surgery to widen the opening of the sinus to promote drainage, or we can remove the polyp that obstructs the maxillary sinus ostium as well through endoscopic sinus surgery. A more important factor in the management of chronic sinus infection is the removal of the cause. So if the cause is odontogenic factor or infection from dental origin, you have to remove the infection either by endodontic treatment and episectomy and removal of the periapical lesion, or extraction of the offending tooth. Moreover, why we widen the ostium of maxillary sinus, why we relieve the obstruction of the sinus, why we should allow aeration or entrance of the air to the sinus, because blocking of the sinus drainage result in conversion of the aerobic bacteria within the sinus into anaerobic bacteria, which is more severe and aggressive, which require more aggressive treatment.